I'm Lien Deschuytere. I'm the rhinology fellow in UCT. And as requested by the registrars on this side, I will be giving a more teaching lesson today about the diagnostics of unilateral nasal mass. So we'll start with a little case presentation. The first case is about a 57-year-old male patient who visits you in clinic. He has a unilateral left-sided nasal obstruction since 1 year, and he also has unilateral headaches as well as recurrent epistaxis. He has a history of hypertension and smoking, but is otherwise in good general health. The second case is a 2-month-old girl who has respiratory problems while feeding, as well as epiphora. The parents noted a unilateral mass in the left-sided nostril, but otherwise she's in good general health. When you have these two patients in your clinic, your differential diagnosis will be completely different between the adult case and the pediatric case. So for adult cases, you either think of benign lesions or malignant lesions. For benign lesions, you can think of inflammatory causes such as a rhinolid, nasal folliculitis, septal abscesses, sinonasal polyposis, AC polyps, or more neoplastic lesions such as an inverted papilloma, an osteoma, a pyogenic granuloma, and others. For malignant lesions, you can either think of an epithelial malignancy, such as a squamous cell carcinoma, an adenocarcinoma, a mucoepidermoid carcinoma, and others, or a non-epithelial malignancy, such as a rhabdomyosarcoma, which is more rare. When you think about the children, your differential diagnosis will be completely different. Malignant cases are much more rare, so you think about benign cases first. So for the benign cases, of course, you also always think about the foreign body, but they can also have polyps, sinonasal polyps or AC polyps, or vascular lesions, especially in adolescent males. You must always think about the juvenile nasopharyngeal angiofibroma, but also about hemangiomas and arteriovenous malformations. For neoplastic lesions, we have the typical midline nasal masses, such as an encephalocele or a meningoencephalocele, which is a herniation of brain tissue through a skull-based defect, whereas a glioma also contains glial cells, but is actually pinched off from the intracranial compartment. A dermoid cyst is another midline nasal mass. It contains mesodermal and ectodermal elements, as well as adnexal tissue, such as hair follicles, sweat glands, and others. Another thing to think about is a dacryocystocele or a nasolacrimal duct cyst. This happens in neonates when the distal nasolacrimal duct is obstructed, so tears actually accumulate and form a cyst. As told before, malignant cases are very rare, but can occur, such as a rhabdomyosarcoma. If you start a workup for these lesions, you begin with a very thorough history. So you ask about the nasal complaints, the onset, the duration, the laterality of the complaints, as well as the associated symptoms, such as smell disorders, taste disorders, epiphora, allergic symptoms, history of previous operations. You also ask about ear complaints and other complaints in head and neck region, such as lymphadenopathy, proptosis, visual changes, etc. After your history, you continue with the clinical examination. You first perform an external nasal exam, because sometimes you can even see part of the lesion on the outside. So look for deformities of the nose, look for small pits or fistulas, do an anterior rhinoscopy and a nasal endoscopy to see the extent of the lesion. When you have a midline nasal mass in children, you can also do the Furstenberg's test. So you compress the internal jugular vein, and this causes an encephalocele to enlarge, but the glioma that's pinched off from the intracranial compartment will not enlarge. After that, you do a head and neck exam just to feel for facial tenderness and look for cervical adenopathy if present. An otologic exam is also mandatory. And if you suspect any involvement, please also do a full cranial nerve examination and an ocular examination. I will continue with a few pictures just to show you. So the lesion on the left is a warty-like lesion. To me, it's quite typical aspect of an inverted papilloma. This also appears to be on the final histopathology in this case. But the lesion on the right looks more or less similar but it was in fact a squamous cell carcinoma. So you can't really tell based on the looks only what it actually is. For the next case, if I told you that the person in the left picture was a young adolescent male with this highly vascular lesion, you would almost be sure it's a GNA. But the lesion on the right looks more like a polyp, but also was a GNA. So you must always be careful that even polyp-like structures can be vascular lesions. Other pictures. So these two pictures are both encephalocele. They have that bluish aspect, but you can easily mistake them for polyps as well. So one must just always be careful not to forget about all the other differential diagnoses. And then last one is I'm showing you because it's quite typical. So this child on the left has a dacryocystocyst. It's very typical. You just see it. Yes. You see a bluish swelling on the medial canthus in a child that has, epiphora or nasal obstruction. So that's quite typical. But on the other side, this child has bilateral dacryocystocyst. So you can see it on the right side. There's a bluish swelling. The left side is actually normal external. When you did the nasal endoscopy, however, there's a nasal cyst on both sides, as you can see on the scan as well. So it's not always clear on the outside. It might be only clear on the inside. So just to show you. After clinical examination, we continue with imaging. In an ideal situation, you should always do imaging before you take a biopsy. Although imaging alone will never be enough to make your definitive diagnosis, and a biopsy remains necessary. The goal of imaging is one, to show the extent of the tumor inside the nasal space or outside. And second, to alert the clinician to occasions when it's mandatory not to perform a biopsy. I will come back to that later. However, in resource-constrained situations, sometimes difficult to get imaging first. So you can consider a biopsy in clinic before you have the imaging, but really try to take a deep representative biopsy, because otherwise they are often inconclusive. So when not to biopsy, I actually suggest you never take a biopsy in pediatric cases, because they're often benign and they might have an intracranial extension, such as in meningocele. Also, don't take a biopsy when you see a vascular aspect of the lesion, especially in adolescent males. Always think of a GNA. Even if it looks like a polyp, it's best just not to take that biopsy. Although imaging alone, you have a few types of imaging. Radiographs aren't actually used anymore. We do use CT and MRI. CT is used for the superior bone contrast. You can see bony invasion, bony erosion. You can use it for your navigation perioperatively. And there's different types. So you have the non-contrast CT, the contrast enhanced CT, and the CT angiography for highly vascular lesions. MRI, on the other hand, gives you superior soft tissue contrast, which helps in defining the intracranial involvement and helps to differentiate a sinus from a sinus filled with fluid versus a sinus filled with a soft tissue lesion. You also have different types, T1, T2, with or without gadolinium contrast. So although imaging alone will rarely be enough to make your diagnosis, there are a few lesions that have some typical aspects. For example, an inverted papilloma usually has a bony thickening or a focal hyperostosis at the attachment site on CT, as you can see here. This is very important to see preoperatively, because you have to be very attentive to this during your operation and take it all away to prevent recurrence. The lesions itself can show internal calcification, and there can be some bony erosion or bowing. Another one is a GNA. So on a CT, you see a contrast-enhancing mass with an enlarged sphenopalatine foramen and an enlarged pterygopalatine fossa. So as you can see here, and this lesion actually pushes the posterior wall of the maxillary sinus forward, as you can also see on this one. That's a Holman-Miller sign. It's very characteristic for a GNA. On MRI, you can see multiple phloivoids as well as on T1 as well as on T2. You should order this just to rule out any extension beyond the sinonasal compartment. For the midline nasal masses, you do perform CT and MRI just to exclude intracranial connection. So on the picture on the left, this is a nasal dermoid. You can see this just this lesion, there's no attachment to the brain. The other two here are both encephalocele. So on this CT scan, you can really see the skull-based defect showing the connection. And here you, on the MRI, you can see this connective tissue. So it helps you to guide. A dacrocystocele is, I've told you before, it can be quite clear clinically, but if you don't see it clinically, you can also perform a CT scan. The CT scan will show a nasolacrimal duct dilation and a well-defined thin-walled cyst at the medial canthus or intranasally, just below the inferior turbinate. After you've had your biopsy, your imaging, you continue with a biopsy. Depending on the pathology in the patient, this can either be done under local or general anesthesia. The advantage of local anesthesia is that it's very quick, it's convenient, you don't need any theater time. And the disadvantage is that it's often inconclusive. So really try to take a deep representative specimen because the superficial tissue is usually inflamed or necrotic. The advantage of doing it under general anesthesia is that it usually gives you a representative specimen. You can actually debulk the lesion, take a deep specimen, and this will tell you a lot about what it is. In the same setting, you can also do a thorough evaluation of the extension towards the orbit, infratemporal fossa, etc. But it does consume theater time, so it's not always possible. If your preoperative biopsy is inconclusive or shows an inflamed polyp or necrotic tissue, while you have the strong feeling that it might be something else, you can consider either to take frozen sections intraoperatively and then decide during the operation how you will extend your surgery, or you can first perform a formal rebiopsy under general anesthesia first and do a full procedure in second time. You just have to discuss it with your patient and go on. For the treatment, so as the differential diagnosis between pediatric cases and adult cases is completely different, so is the treatment. So we go back to this differential diagnosis, and if you have a look at the benign lesions, so a foreign body will just be removed. A polyp will either be removed or medically managed if it's a sinonasal polyp. For the vascular lesions, a GNA is preferably excised. This can be endoscopic or open, with or without preoperative embolization. Radiation is only considered for residual tumors or tumors with intracranial extension or non-operative candidates. Chemotherapy will only be used for failed surgical and radiation therapies. There is some evidence about hormonal therapy. This might decrease the tumor size and the vascularity, but it's not routinely used at this moment. For hemangiomas, you can either have a conservative approach, or you can use a beta blocker, a propranolol, or you can excise it with or without preoperative embolization. For an arteriovenous malformation, you will also do an embolization and excision. For the benign lesions, so for the midline nasal masses, the encephaloceles, gliomas, dermoid cysts, you will usually do an excision with or without closure of the dural defect if necessary. A dacrocystocele will usually resolve spontaneously by 9 months of age, but if there's an infection or some respiratory problems, feeding difficulties, you can do an endoscopic marsupialization of the cyst. Antibiotics are only necessary, with excision is only necessary when you have recurrent infected lesions. So the malignant lesions in children are very rare, so I won't go into detail of those. It's a case-per-case management. For the adults, we also had this differential diagnosis. And if you go back to it, the inflammatory lesions are either removed, incised and drained, antibiotics are used. For polyps, you can do a medical management or surgery. As AXT polyp will usually just be removed endoscopically. For the neoplastic lesions, they will also usually just be surgically removed. In inverted papilloma, you have to be very careful about the attachment site. Really try to drill that away so you prevent recurrences. Radiation is not really recommended at this time. And osteomas will only be excised if they're symptomatic. So if you see an osteoma without symptoms, you just actually leave it. For the malignant cases, for more generous approach, the early stage malignant sinonasal cancers will usually be treated with a single modality treatment, either surgical resection or primary radiation therapy. For lesions in advanced stage, you will have a multimodality therapy with either primary surgical excision and postoperative radiation or primary radiation with surgical salvage. If you have inoperable patients for whom resection would result in severe cosmetic and functional morbidity, you can start with primary radiation therapy to reduce the lesion and then do a surgical salvage. If you have non-operative candidates, you can consider primary radiation, chemotherapy, or a combination of those two. For the neck lesions, so if there's an N0 neck with a sinonasal carcinoma, an elective neck dissection is usually not indicated because the risk for occult metastases is only less than 10%. So only clinical nodal disease will be treated. And when you have N1 to N3 neck, a neck dissection is recommended. If parotid nodes are involved, this requires superficial parotidectomy. Some non-squamous tumors, for example, that rhabdomyosarcoma, may benefit from chemotherapy as well. So this was very short a summary about the diagnostics of a nasal mass. These are my references, and I'm happy to answer any questions.
Can I ask a question?
Yes.
So you said that you shouldn't biopsy, obviously you do the JNA, you should biopsy, but you put on your, the other reason to not biopsy is it's a sarcoma. What would lead you to think that it's a sarcoma?
So sarcoma, clinically, yeah, it also has a very vascular aspect. So if you see a lesion with a lot of vessels on it, it might be a sarcoma as well.
Okay,
any vascular, don't take a biopsy in clinic because you'll end up in trouble.
But as you say, like a JNA can also present with a mass that looks as if it's just polypoidal.
Yeah, so that's why they recommend to do imaging first. It's not always possible, I know, but in adolescent males, just watch out. Any other questions? Oh.
Yeah, just to comment, it's very important topic. And just on the non-benign adults, it's often sinonasal, are often quite a young presentation. We had two recent. She was a nasopharyngeal. She was like 35 and had already gone into the brain, and she's apparently been presenting, blockage symptoms for 3 months. So it's not to miss it or disregard it because of young age. Nothing bad when presenting.
Okay, if there's no other questions, we'll conclude this meeting and we'll see you next time.